to you about dermatoses in pregnancy. I don't know about you, but dermatology is not something that I've ever felt very strong in. However, in pregnancy, there are a few skin conditions that we need to be aware of. One, because we'll see quite a few of it, and two, there are two that we need to be aware of because they have the effect to be so detrimental to our mom and baby. So we're going to review these today, and here are the objectives for our lecture today. So I want to review the common skin conditions related to or caused by pregnancy, and review the 4 categories of skin condition classifications, because I think that kind of helps organize us, especially when someone comes to us and presents a rash. It will help us kind of know how worried or not worried to be about it, and then understand which conditions will lead to those serious adverse outcomes that we need to be concerned about. So let's look at those classifications. And a lot of this comes right out of your Varney textbook. There's a great table in your book that I really would encourage you to look at. It's in chapter 22. You can look at that, and I think it organizes it well, and it's a great thing to study for boards. So the skin conditions are all related and caused by a physiologic aspect of pregnancy, really most likely hormones. And the 4 categories are atopic eruption of pregnancy, hepatic cholestasis, pemphoid gestationalis, and polymorphic eruption of pregnancy. Now, I've organized it in this lecture the way that Varney has organized it. Your Williams textbook has organized it a little bit differently. They actually have a whole section devoted to hepatic cholestasis because ICP is fairly significant. They have it in a different chapter. You'll definitely want to review that. And then they have chosen to organize it a little bit different in their dermatology section. But I kept it consistent with Varney because that is more in line with how we look at things. So the reason that they have organized these skin conditions the way they have and in the categories and classifications that they have is that they're differentiated by what they look like or their appearance, where they're located on the body, and when they erupt during pregnancy, so whether it's first trimester, second or third trimester. So that's what got the different rashes categorized the way that they did. The only 2 that are really nerve-wracking for all of us are ICP, that cholestasis, or pemphoid gestationalis. Luckily, those 2 are super rare. The most likely one that you're going to see is this atopic eruption of pregnancy. And as awful as this picture looks, and I know that it does look terrible, it really is a benign condition. And about 50% of all of the rashes that we see will fall in this category because it actually contains 3 types of rashes. Eczema and what's called perigio, which just refers to really intense itchy spots. It's a very fancy word for itchy spots. And then pruritic folliculitis, which are like small follicular pustules that are all over the trunk. And all of this usually starts in the first or second trimester. The good news is there's no adverse effects to mom or baby. It goes away after delivery. The bad news is that, oops, I spelled this wrong, is that there is a possible reoccurrence with future pregnancies. It's just the way this woman's skin is responding to the hormones that the placenta is producing. So we treat it with topical Benadryl and oatmeal baths, and she can take oral Benadryl in the evening because you don't want to give it to her during the day because she can get really sleepy. But that's basically the best way to be treating this type of rash. If it gets really, we can also give oral corticosteroids. If it's severe eczema, they can do an ultra-potent topical corticosteroids. but at that point you probably would be co-managing with an MD or sending her to dermatology for a consult and having them order something. So that's atopic eruption of pregnancy. So then moving on to intrahepatic cholestasis of pregnancy, or ICP, the difference with this one is that they still will have the severe itching that they do with the atopic eruptions, but they don't have a rash. And that's your big clue that there's something different here, is that they're super duper itchy. Sometimes they'll even have scratches on their skin, but there won't be any rash that you can see. The good news is that it's rare. It's less than 0.5% of pregnancy. And the pathophysiology is that it's a slow emptying of bile from the gallbladder, and so that there's some type of buildup of that bile salts in the skin or something that is causing that itchiness. So the risks that you can see here: advanced maternal age, a family history of hepatic disease, a history of hepatitis C themselves, sometimes a twin gestation or more, cholestasis themselves, or high dyslipidemia. Those are all risk factors that they could have. The reoccurrence rate is 60%. I wrote later that there is a possible reoccurrence rate, but it is about 60%. Other things you want to be thinking about are HELP, preeclampsia, hepatitis, or any other liver disorders, because all of that is that their liver is something that we're concerned about. It does take about 2 to 3 weeks after delivery for this to go away. So there is a bit of time for this to take for it to go away, and that is somewhat disheartening for our patients to realize. The diagnosis is made by drawing labs. So we would draw we would draw serum bile acid levels and look for elevations there, that hyperbilirubinemia. Try to say that 3 times fast. We also look for hepatic amniotransference levels. We would usually see them be mildly increased. And then we would also do a liver function test, so ALT, AST, and they would be mildly increased. But our big clue is going to be that itchy skin without any rash. In fact, if she is itchy enough, and I wrote that here. Well, let me just keep going. The elevated bile acids are really going to be our biggest indicator and our biggest marker for ICP. But because that risk for stillbirth is so significant, if she is, I did the wrong thing, pruritus, sorry. If she is itchy without rash, that's enough for us to make that presumptive diagnosis and start treatment without waiting for the labs, because we are so concerned about stillbirth for this baby. So if you are really thinking that she has this, it is okay to go ahead and start treatment while you're waiting for your lab results. We can always stop the medication if it comes back and her labs are okay. So don't wait for labs if you're pretty certain that she might have this. Go ahead and start, and you would be consulting with your MD as well. So the itching, when we're looking for this, the itching usually starts on the soles of the feet and the palms of their hand, which is also different from the other rashes, which are on the trunks of the body, on the abdomen, and usually on the upper thighs. So that's the other big indicator, is you've got this woman who's super duper itchy on the soles of her feet and on her palms, but you don't see any rash. And like I said before, that itching may precede that lab value changes by several weeks. So she might be complaining of this for a visit or 2 even before you see any lab value changes. The treatment are antihistamines and topical emollients to relieve that itching. But the big one that we give is this ursodiol, and you can see the dosage there. And that is the most effective to bring down those bile acids. The maternal risks are minimal. It's just the kind of psychological stress of the itchy skin. I mean, can you imagine how much that drives them crazy to not get sleep, to be constantly itching? They can get a vitamin K deficiency, though I've never seen that. And then an increased risk of future liver disease, but this is not common. But the big one, the really big one, is the fetal risk. Preterm birth, meconium ileus, but the sudden stillbirth. And the thing that's scary about this is that stillbirth can happen rapidly and without any warning. Like, you can have a baby that looks really good on the monitor, and an hour or 2 later, be gone. So it's rapidly and without warning, like I said, you can have a reactive NST and 2 hours later your baby is gone. So we usually will induce these kids by 36 weeks when we have a mom with ICP. MD consultation and AP testing should begin immediately upon diagnoses. And management, because like I said, is antenatal fetal testing, BPP, and Doppler studies should begin with that diagnosis. We're going to do everything we can, as much as we can, to reassure ourselves that baby is doing okay. Delivery is recommended once we know those lungs are mature, or if testing is not reassuring. We'd rather have a premature live baby than a dead mature baby. And like I said, due to that sudden nature of the stillbirth. So delay in treatment puts the fetal at much, much more risk than it does the mom. So that is really, this can be pretty scary, and so we do take this pretty seriously. So then, pemphigoid gestationalis. This is something that is so rare that in my entire career I've never seen it once. So rest assured that this is not something that you'll probably deal with a lot. It is a very, very rare autoimmune disorder. It used to be called herpes gestationalis because it looks so much like chickenpox or a herpes zoster. It has those, like you can see from this picture, it has that kind of herpes vesicle look to it, but it's not. It has nothing to do with it. It's not even in the same family. It's most likely seen, it's among Caucasian women and multips in the 3rd trimester. However, I do want to point out to you that when you're reading your Williams text, Williams does say that it happens most often in primeps, but all of the other literature that I've read says multips in the 3rd trimester. And I didn't finish that sentence, but Williams does say primes in the 1st trimester, and that is not what the rest of the literature says. It looks very similar to herpes. But they also act like they have herpes, so they get this prodrome feeling of like they don't feel good, they have nausea, a headache, they just feel like they're coming down with a flu, and then after that they get this itching and they get these like urticaria plaques, and they usually start around the umbilicus on the abdomen, and then it spreads out to the extremities. So the blisters are the last thing that form. If you can see around the blisters on the picture, there's kind of these red kind of urticaria plaques, and there's also those like little papules. That's what you see first, and then the bullae and the vesicles erupt after that. So the risk with this one and what we're concerned about, the mom has an increased risk for developing Graves' disease, and it does reoccur for most and is usually worse in the subsequent pregnancies. But the big one is low birth weight, which is what most of the literature says. Williams also says fetal growth restriction. Prematurity is another big one that we're worried about. There's about a 5 to 10% risk that this will get also transferred between mom and baby. So treatment for this, we give topical steroids, we give topical and oral antihistamines. We'll also give oral prednisone. If it progresses to that blister stage, we'll need to give corticosteroid. She'll need antenatal testing in the 3rd trimester, which includes those weekly BPPs and Doppler studies, because we really begin to get worried about placental insufficiency. And this would be someone that you would be either transferring or co-managing with your MD. Infants, if that transfer does occur and infants are born with it, that you don't need to treat them. It's a virus that will resolve on its own. But it can take weeks or even months to resolve. There's a 50 to 70% chance that it will reoccur in future pregnancies. And then the last skin condition to talk about is PUPS, or puretic urticarial papules and plaques of pregnancy. This is also something fairly common. It occurs in about 1 to 300 to 1 in 130 pregnancies, completely benign, thank goodness. It usually begins late in the 3rd trimester and persists until birth. And it's definitely more common in your primes and those who have multiple births. It seems to always start in those stretch marks, but it can also spread to the trunks and extremities. And I feel like it also is like it also seems to happen a lot in like the backs of the arms and in the backs of the thighs. It's really red, it's painful, it's super duper itchy, but it's been completely benign and nothing to worry about. It is different than that. It's different than the atopic eruption of pregnancy. It's not. It does not fall into that category. So it is something to note that it is different than that, because it's not eczema, it's not prurigo, and it's not the folliculitis. So it's not a blocked folliculitis. So we usually just treat this with antihistamines. We can give them a topical steroid cream if it gets really bad, but it's really just palliative treatment for the most part. And it usually resolves fairly quickly within, well, it doesn't feel quickly to them, though, to be honest, it feels like a long time. But it can reoccur within 4 to 6 weeks after it starts. So sometimes it stops even before they're done being pregnant. And it is unknown whether or not it will recur in any future pregnancy. So that is all that I have. I just the majority of this information came straight from Barney and Williams, and the references that I have are just mainly for the images. So please post any questions that you have in the general forum. Otherwise, have a great day.